Hello, everyone, and thank you for joining. This is Sabrina Paganoni, and this is the weekly ALS Platform Trial webinar. So thank you so much again for joining June 22nd. As always, we will love to provide you real-time updates about the trial. So I'll do that first. And then tonight, I'm very excited to have with me Dr. Ladha from the Barrow Neurological Institute, who will talk about his extensive experience with lumbar punctures, and actually created a phenomenal video that we're happy to premiere with you tonight. And as always, I'm joined by our patient navigation team, and we have Alison Bullock with us tonight. But first, I'll just give you quick updates about the trial. Next slide. As you know, the patient community has been asking us to give updates about the ongoing regimens and enrollment numbers, and that's what I want to do now. We are enrolling for 2 regimens in the platform trial. So far, we have included 7 drugs. Enrollment has completed, and some of the studies have actually completed for the first 5 drugs, but we are actively enrolling participants to test 2 new drugs, known as regimen F and regimen G. Next slide. So if you are interested in participating in the trial, this is available at many sites, and we have a website that we continuously update every day. Really, we have new activations and new sites joining us. So please check the status of the site near you on our website, or you can always call our patient navigation team. Next slide. So what are the numbers? So you can see the numbers on the slide. Again, we update them every week. As always, participants need to first consent to the platform trial itself. That's kind of the first step to get into any regimen. And then from the sort of general master protocol or general consent for the platform trial, participants are then assigned to any of the available regimens. In this case, we have 2. So you can see the numbers for regimen F on the slide. We continue to make progress. And then at the same time, more recently, we also opened regimen G. So if you can go to the next slide, we can see that also regimen G is making progress. Again, the concept is the same. People need to first sign informed consent for the master protocol to enter the platform trial itself, and then they are assigned to a regimen, and then they flow through the regimen so that they can eventually participate. So again, making progress on both regimens. The reason that we have lower numbers for G is simply because we started just a few weeks later, but we are hopeful that these numbers will continue to increase. So thank you so much to all of you who are trial participants, or if you're supporting someone in the trial, we deeply appreciate that. Please spread the news, because we have literally hundreds of spots available across many sites across the country. So we really want to include as many people as possible and as rapidly as possible, so that we can tell if these drugs work. Next slide. We do have a variety of resources on our website, and I really want to thank our patient navigation team for working with many patient advisors and caregiver advisors from our committees to develop a number of resources that are available on our website. They can be printed, they can be shared digitally. We have a variety of tools, and again, they can all be found by following the link that you can see on the slide or the QR code. Next slide. And so we host a drug-specific webinar, which is a little bit longer than our usual weekly updates for every drug, every new drug that we include in the trial. So we recently had one for regimen F. The recording is available, and we're very excited to also host a drug science webinar for regimen G that's coming up on July 20th. So please mark the date. Next slide. And without further ado, I'm really excited to introduce our colleague, Dr. Ladha, who is the site investigator at BNI in Phoenix, Arizona, also a close collaborator, regimen lead for regimen E. So thank you so much for your work on that as well, and expert on many things related to ALS. And for tonight, we're really excited that he will talk to us about lumbar punctures. So Dr. Ladha.
Thanks, Sabrina, and thanks to the NEALS team for having me, and thanks to Allison for helping organize this. So, you know, I think, especially with this regimen, but throughout my career with ALS, we've seen that lumbar punctures can kind of be a little bit of a hot topic, and so I've now been at Barrow doing lumbar punctures for a lot of our biomarker research for 10 plus years. And I've seen this be a consistent theme that when you address someone about having a lumbar puncture, the first thing that happens is a look of horror on their face that I've heard about lumbar punctures. They're terrible, they're awful, they're painful. And my experience has not been that. It has been that most people do very well with lumbar punctures. And I've been sort of struck by the discrepancy between the reality of what a lumbar puncture is and what people sort of know about a lumbar puncture from mainstream media or movies or other things. And so it's been one of my missions to sort of educate people about the lumbar puncture. And part of that is educating people about what the experience is like. I've actually had 2 lumbar punctures myself. And so I learned firsthand that, this isn't the worst thing ever. But part of it is also to educate people about why it's so important. Biomarker research has led to a lot of, potential therapeutic options in the ALS pipeline. And CSF biomarkers are really important to what we do in ALS and how we're going to develop the next phase of therapies. So I think because of both of those reasons, I thought it was important to talk about lumbar punctures broadly with people to really hopefully educate people and answer questions about the lumbar puncture. So today, that's kind of what we're going to do. Next slide. Okay, so this is a little video that I created for our site initially. The video in its full length actually has a real lumbar puncture being performed. We kind of cut that out for a variety of reasons for this, but really this is meant to be a broad overview of lumbar punctures in ALS, why we do them, and what the procedure is like. Let's go ahead and start it. Lumbar puncture 101. So what is a lumbar puncture? Well, it goes by several different names, including spinal tap, LP, or lumbar puncture. The process involves using a small needle to access the cerebrospinal fluid, or CSF, in the lumbar spine. Why do we do spinal taps? What is the purpose? Well, from a standpoint of ALS research, motor neurons live in the brain and the spinal cord, and they're constantly bathed in the spinal fluid. This provides us with much more direct information than blood or MRI or even EMG testing, which are all relatively indirect methods of getting information about the motor neurons. What can CSF tell us? Well, it may tell us about the cause of ALS in a given patient. It may provide us with protein or other markers that allow us to track the disease progression over time. This can be very useful in the clinic, but also in a clinical trial. Finally, collecting spinal fluid allows us to tell if a drug has actually gotten to the motor neurons. Here's an animation of the lumbar puncture. It's often performed in the office setting or in the radiology suite. The patient is asked to lay on their side or maintain a seated position. The needle must avoid important neurologic structures such as the nerve roots or the cauda equina and the end of the spinal cord called the conus medullaris. Generally, the procedure is performed at the L3-L4 lumbar space, which is well below the conus medullaris so that there is no risk of injury to the spinal cord. The patient usually leans over a table so that the back is arched and the spaces between the vertebrae are opened up to allow the needle to pass unobstructed. After sterilization of the skin, a small needle is used to inject a local anesthetic, such as lidocaine, into the skin and the tissues overlying the spine. Once the area is sufficiently anesthetized, the spinal needle is advanced until it reaches the spinal canal. Although the needle may come into contact with the nerve roots, they are floating in spinal fluid and move away from the needle, preventing damage from occurring. Once the needle is in place, the spinal fluid drips from the needle hub under the natural pressure of the spinal canal.
and 10 to 15 milliliters of fluid is collected in sterile vials. This entire procedure usually takes between 20 and 25 minutes. The needle is then removed, and the patient is asked to lay flat for approximately 1 hour to allow the small puncture site of the spinal canal covering to heal and for the spinal fluid to regenerate. The lumbar puncture is a safe and common procedure. It is critical to obtain spinal fluid for ALS research if we are ever to find a cure for this terrible disease.
Okay, so I hope that sort of covers a little bit of why we do the lumbar puncture and sort of shows you how it's performed. Our experience again has been that it's a fairly safe and relatively painless procedure. In talking about the risks, the primary risk that we generally talk to our patients about is a risk of headache, and headaches can happen, at least in the medical literature, they're estimated to happen at about a rate of 30% of lumbar punctures. Throughout our time doing these in ALS research, we've used sort of a special needle called the Sprott needle or the atraumatic needle. And we've been able to really demonstrate that there's a substantially lower risk of having headache with this needle. So we feel like in using this needle, we've really reduced most of the side effect profile in doing lumbar punctures. And this needle is broadly used now across most ALS studies, especially NEALS studies. So the HEALEY Platform Trial and any other NEALS biomarker study uses the atraumatic spinal needle. And we've really found that it's been helpful. Other than headache, for the most part, the only other real risk that people have is some risk of back pain. And you could imagine that anytime you put a needle under your skin or in your back, you're going to have a little pain for a day or so after that, but that usually dissipates quite rapidly. So hopefully everyone on the call kind of understands better about the lumbar puncture and why it's so important. I really encourage you to talk with your physician if you're thinking of being part of either the platform trial or any trial that requires a lumbar puncture. Talk to your physician about it, find out at their institution how they do it, whether it's the neurologist who does it, the radiologist who does it, what kind of needle they use. And hopefully I've convinced some of you that the lumbar puncture isn't a terrible thing and really shown you how helpful it can be to ALS research. I'm happy to take any questions at this point.
Thank you, Dr. Ladha. We have actually had quite a few questions come in prior and during the video, so we'll just get started with that.
Okay.
The first one, very interesting. We hear a lot about how lumbar punctures are required in trials now or ask for consideration from the participants. The question is, why weren't these required before, but now they are? What's changed?
Well, they're not always required. So we have a lot of trials where it's optional. We would love to get that data, but we don't expect in every trial that people have to. Now, the times that it's required usually relates to one of two reasons. One, the mechanism of the drug requires that we know what's happening in the spinal fluid with that drug. So that might be one reason. The second one might be that we want to be able to be sure we can detect the drug in the spinal fluid. So those are probably two good reasons why this trial is requiring the lumbar puncture. The rest of the platform regimens, actually lumbar puncture was available and optional for. So it's not that we didn't want this data before.
Got it. Okay. During a lumbar puncture, what if fluid is not able to be drawn, or is it the case that it is always able to be drawn?
It's an extremely rare occurrence that there's no fluid that's able to be drawn. So as you saw in the video, we don't actually draw the fluid out. It just drips out on its own accord. Now, if the needle is pushed up against something, so the little hole in the needle is blocked, I suppose that could happen. There are times unrelated to ALS, but there have been cases where people have tumor in their spinal canal and it's taking up all the space. and so there's really no fluid there to remove. Those would be scenarios where you might not get fluid, but I'm not sure I've ever seen that happen, at least as long as I've been doing lumbar punctures.
Perfect. Is there a risk in doing repeat lumbar punctures, like over a long period of time? Is there too much of a good thing?
Yeah, we don't think that that's the case, and you know, our experience has not shown any long-term adverse events from repeated lumbar punctures. I have people that I have done upwards of 30 or 40 lumbar punctures on over the course of 4 years or so, and they never seem to have any problem. They don't develop excessive scarring back there or pain. Maybe the worst thing you would see from that is that actually there's a little spot now that I can see after doing them several times on a person, but really all that does is help me make it easier to find where I'm going when I do the next one.
Those people are kind of heroes, so thank you to them.
Yeah.
That's incredible. Have you ever experienced any leaks associated with lumbar punctures?
Yeah, so leaking is probably the cause of the headache that I mentioned. And so those are reported in lumbar punctures. They can be uncomfortable in that the headache that people get from a leak is quite bad. The vast majority of leaks will seal up on their own. And on the occasion that they don't, we generally do something called a blood patch. And that's where we take a vial of someone's own blood and put it right back in the same spot. And the idea is that we think that sort of seals up that hole. Most people who have a blood patch after having a leak have relief of their headache nearly instantly, and it goes away. Again, going back to the needle type, the Sprott needle or the atraumatic needle tends to greatly reduce the chance of a leak. And so that's why it also reduces the chance of a headache. So we have not really seen many leaks at all over the years I've been doing that here using this specific needle.
That's good. So some participants who've experienced a lumbar puncture have said that hydrating in advance seems to really help with the risk of a headache. Is that your experience or anything you could suggest for people to do in advance?
Yeah, I think hydrating can help. It certainly helps us if someone's well hydrated. It's easier for the fluid to come out, or it drips out a little faster. We tend to talk a lot about what to do after the lumbar puncture, and so some of this has good science behind it. Some of it is sort of, we just sort of do this because we've always done it. But some of those things are after the lumbar puncture, staying hydrated. We often tell people to have caffeinated beverages, which if you have a headache, which may help. We have people lay flat for about an hour after the lumbar puncture. And we tell people to not do any strenuous kind of activity that would cause them to bear down or raise the pressure, which might kind of precipitate a leak or propagate a leak.
You know, I know I've heard some of the fear of lumbar puncture is the question, who will do it? Who does that at the clinic?
Yeah, so it varies from center to center. At our clinic, I do pretty much all of them as they relate to ALS. There are some centers where they have a radiologist or an anesthesiologist do it. And I think it largely depends on the experience. So maybe some neurologists haven't done many and are not comfortable with it. It may have to do with workflow within a clinic and how much support staff a clinic might have. Do they have the time in the clinic or the space to do it? So there's a lot of variables which go into who actually performs the lumbar puncture.
Okay, I'm sure if anybody has that question, they can ask in advance of their team.
Yep, absolutely. It's something that you can talk to about your team, who does it. I guess along with that, I should include the video shows some local anesthesia, and I think that's the most common way. We try to numb people up, which may be the most uncomfortable part. The numbing medication is just like Novocaine that people get when they go to the dentist, and when it's injected, it burns a little bit. After that, most people are really fairly numb. They may feel some pressure as the needle goes in, but they don't usually feel any sharp pains or anything. Now, there are places that may actually use sedation or something like that. I would say that that's uncommon. And especially with ALS, we try to avoid sedating our patients because we don't want them to have respiratory compromise or anything like that. So the vast majority of places will use just local lidocaine or local numbing medication.
That makes sense. We've all heard that you also collect specimens from healthy volunteers. So a question came in asking, what do you do with those samples and how many do you need to compare?
Yeah, those are like gold in our NEALS biorepository. So as you can imagine, finding people who don't have any disease and are willing to have a lumbar puncture just for the heck of it are few and far between. We've been pretty successful here. A lot of our pals, family members are interested in being part of this. So in our biomarker studies, we try to recruit from that group and have been pretty successful. Family members are great people for being healthy volunteers because they have the same environment. They, especially if it's spouses, they tend to be about the same age. So we'd like to try to have samples that we can match with a patient based on age and environment, because that takes some of the question out. When we're looking at ALS research, no one's sure what causes ALS. We think, environment may play a role, but it's clearly not just environment. And so if you have people with the same environment, you at least take that off the table as a question when you do ALS research. So those samples are used as comparators. You can think of healthy control samples as, at least in the lab, as a placebo. And that's really the placebo group that is used in the lab, in the research lab.
So you probably got everybody so excited to want to do this, Dr. Ladha, just now. So if family members and such are interested, do they contact their own individual clinics, or is there a central place to do that?
Yeah, so there's a variety of biomarker efforts underway. One of the larger ones that we're part of and is associated and affiliated with NEALS is the Target ALS biomarker study, and there's sites around the country that you can reach. I'm sure it's on the Target ALS website, and it's on clinicaltrials.gov. And so if your center doesn't have a biomarker study or a sample collection protocol and you're still interested, those sites would be more than happy to have you come out. Generally, those visits are infrequent. If you're a healthy control, most of the time we want 2 time points. So you would have a lumbar puncture and then maybe a year later have another one so that we can compare over time. If you're a person with ALS, then often these sample collection protocols kind of call for every 4 months or so, maybe for a year or 2 years. Some of them might be every 6 months for 2 years, but on average, the biomarker studies, this is not specifically relating to regimen F. The regular biomarker studies collect multiple samples over time. In the platform trial, samples are collected, I believe, twice. So before you start treatment, and then I can't remember the exact time. I think it may be at 12 weeks, but it's somewhere, after you've been on treatment for a while.
So if there are potential participants who have any type of back issues or disc degeneration, are those issues that would prevent this from happening?
It doesn't prevent it. It may make it a little bit more difficult. I found that even if people have had surgery on their back and things like that, we usually can do the lumbar puncture anyway. So it's been really very rare that precludes people from having the lumbar puncture.
If somebody is on a trach, does that preclude them having this procedure?
It shouldn't prevent people from having a spinal tap. It may prevent you from being part of a study that needs a spinal tap. So I don't know if with the biomarker studies, people on a trach are allowed. Certainly in the platform trial, you'd be excluded. And so you wouldn't need a lumbar puncture from that standpoint. But the tracheostomy itself doesn't prevent someone from having a lumbar puncture.
Perfect. So how is the lumbar puncture needle different than the needle used to deliver to a person?
It doesn't need to be different. When we do a lumbar puncture, the procedure is exactly the same whether or not you give tofersen. So it really is dependent on the site that's doing it or the study that's doing it in terms of which needle they use. When I do tofersen here at our center, I use the same needle that I use for all the biomarker studies and all of the platform regimens.
Right. So this is a good question. Logistically, how do you maneuver people to do the lumbar puncture if they want to contribute to science, but they're paralyzed due to ALS?
Yeah, that's a great question. It turns out, I mean, most of the lumbar punctures I have done here have been for studies. And as it happens, for better or for worse, I know this is a little bit of a controversial subject, but we tend to enroll people who are earlier in the disease in studies. And so it doesn't come up all that often that someone is paralyzed to the point that they can't get on the table and do the lumbar puncture. Now, the video showed someone sitting and doing the lumbar puncture. It may happen that someone is weak enough that they can't quite sit comfortably over a table. And in that instance, we lay them on their side on the table. But most patients are able to still get up on the table, at least with some help or with, maybe a Hoyer lift in the room or something like that.
Thank you. Are people who participate in biomarker studies, not necessarily the platform trial itself, are they given access to their data?
Generally, no. Generally, you don't get sort of results from studies. And I think that goes for the platform trial and most of the biomarker studies. And this includes genetic data, which I know comes up quite often. The vast majority of ALS studies use a research lab for their genetics and not what is called a CLIA certified lab. A CLIA certification is required if you're going to process samples and give results back to a patient for their use. And so that's a big, complicated process to become CLIA certified. So most ALS research labs have not done that.
So Dr. Ladha, I'm going to switch gears on you and
Okay.
ask, I know we had to, Dr. Paganoni had to drop off for a family reason, but we do have a couple of questions about the platform trial. I want to see if perhaps you can answer for us.
I'll do my best.
Thank you. And if not, we can always re-ask next week and get the answers for everybody. What dosing levels of the Denali product will be given to patients?
Off the top of my head, I don't know the dose. It's a single dose that was derived from the earlier phase study, where they had a high dose and a low dose, and I believe they selected the high dose, but don't quote me on that. And it's once daily oral dosing.
Perfect. We won't quote you on that. In the exclusion criteria of the Denali therapy, there's a mention of diagnosis of epilepsy and seizures. Do you know why? Can you comment on that?
Again, I'm not 100% sure. I think it is because there is at least animal data that may lower the seizure threshold in animals. And so I think we don't want to see patients who have a history of epilepsy get thrown into more seizures because of a drug. Now, I think we don't really know if that's going to be a significant part of the side effect profile. It doesn't look like it's a prominent side effect, but I think that criteria is there just to sort of be on the safest side.
Perfect. And thank you. I'm going to jump back over to the lumbar puncture side for one last question. Is it helpful to have samples from siblings or twins?
Yeah, certainly it could be. I mean, it would depend on the research question. With familial ALS, we can distinguish siblings by their genetic testing. But for sporadic ALS, if you have a twin where one has ALS and one does not, I'm sure that would be of great interest to some scientists around the world. So I think those would be very desirable samples. The challenge is finding enough of them that you can do larger scale experiments to distinguish, factors that may be within the spinal fluid.
Makes sense. Thank you for that. I want to acknowledge, I know we're out of time, that there are a number of questions about Regimen G that we weren't able to get to today, but we definitely will try to answer them next week when Dr. Paganoni is back. And we do have the science webinar for Regimen D or G scheduled for July 22nd. So that's a great place to ask a lot of those questions as well. So Dr. Ladha, thank you so much for being here with us today and talking about the lumbar punctures, explaining that to us. And thank you to all the participants who joined us today. We look forward to talking with you next week. Have a great evening.
Thank you, guys. Thanks for all the great questions.
Yep. Bye-bye.